Good morning, ladies and gentlemen. Pleasure and privilege to be here at Diabetes India and talking about semaglutide's legacy in obesity management. So, this talk is essentially about obesity, and I will not be focusing on the diabetes part of things. Thanks, Dr. Hari Kumar, for your wonderful words of introduction. So, this is my disclosures, and I will be talking on how semaglutide causes transformative weight loss. There is, of course, other things that we always want benefit plus. And of course, we will be discussing how it has been used worldwide and practical know hows of how to use semaglutide. I think it's relatively new still, so we need to know how to use this molecule. And I think all of us are learning. So I will be giving you a brief insight on how this drug has to be instituted in patients. So we know for a fact that uh, obesity is a really stunning disease in the sense that the moment you lose weight, the weight comes back on. It's nature hating a vacuum, and lifestyle helps to a certain extent with weight loss of about 3 to 5%, but that is gained back very easily. And the other option is to go for bariatric surgery, which is quite an invasion of a person, and that leads to 25 to 30% of weight loss with its own incumbent side effects and problems. And it is here that you need certain group of drugs, and it's been God sent that we as a generation are being exposed to groups of drugs which actually cause significant weight loss to the tune of almost bariatric surgery, with more drugs expected in the pipeline, which will continue to produce this kind of impressive results. So we will be talking about semaglutide, and semaglutide is a GLP-1 receptor analog with 94% homology to GLP-1 and has a half-life of 7 days. So you can inject it once a week. It works on the brain, various parts of the brain, including the hindbrain and the hypothalamus. Now, I think this is an area where I will talk about in a little bit of detail just to tell you about how obesity works. In the past, we always thought that obesity was somebody who overeats, somebody who doesn't exercise, a sloth human being. But it is a little bit more than that. Think about it from this perspective that all of us have this thing tendency, oh, I need to lose weight, I need to diet, I need to exercise. Why don't we do it? Because there is something inside us which tells us, oh, forget it, you can do it tomorrow. There is something inside us which tells us, hell, you didn't exercise yesterday, you're still alive and having a good time today. You can exercise tomorrow. And this we have always thought to be behavioral. Now, research has shown that this is not entirely behavioral. It's probably somewhat behavioral, but a large percentage of this is hormone driven. And there are various hormones inside the body which work finely on the brain, which deal with satiety and craving. And GLP-1 receptor agonists have started to address this satiety and craving. There is this homeostatic regulation wherein we feel hungry and we have to eat to live. So that is homeostasis. But the main problem is hedonic regulation, wherein we've had a breakfast today of a masala dosa and some sambar, and then you see the man next door is having a croissant with some coffee, and you decide, yes, I will also have a croissant and a coffee. This is hedonic. And this is where drugs like semaglutide come in and protect you from indulging. And this is a hormonal regulation. This is not a behavioral regulation. This is somewhere where the drugs work on the hormones to make sure that you're leading a straight and narrow path. So, the semaglutide is one of these group of drugs, and this is the newer generation. 2.4 milligrams is the weight loss dose. 1 milligram or 2 milligrams is Ozempic, which is semaglutide in diabetes. We are not talking of diabetes today. We are focusing almost entirely on the weight loss trials. And essentially, I'll be talking about the uptitration of doses. But as you can see, there's multiple trials that have taken place, including trials in cardiovascular disease, including trials in heart failure, including trials in MASLD, and also versus liraglutide, which is the older generation of GLP-1 receptor agonists. Now, if you look at the weight loss, and this is really impressive, So in this room, considering that there's about 60 people, 1 in 3 who will go on to semaglutide will lose 20% of their body weight. So I'm talking of somebody like me who's 85 kilograms. If I go on to semaglutide and go up to 24, the 2.4 milligram dose, I have a 1 in 3 chance of going down by 17 kilos. Just think of the impressiveness of this data when I put it into arithmetic terms. And this weight loss is not delayed, it starts off early. All of us who are using this drug, and I'm sure many of you in this room will be agreeing with me, that this starts off straight away. So it's not something that you're waiting for years and then you have to tell your patients, oh, keep trying, we will have some results. The results are very impressive. They come back at 1 or 2 months, 4 or 7 kilos lighter. That is something which becomes a huge selling point for this kind of drugs. Forget about the data that you have, and I will show you. And this is something that continues to be held at 4 years with semaglutide 2.4. And if you look at the benefits, 5% weight loss is seen in 90% of patients. So if you're 100 kilos, you will definitely become 95. You can say it with almost definite levels. And if you think of 10%, that's also pretty impressive. 3 in 4. So in this room, if there are 75 people, you know, a large percentage of these people will actually have 10% of body weight loss. Do not think of 10% as very little. If somebody is 80 kilos, it's actually 8 kilo weight loss, which is very impressive. And there'll be 15% weight loss in half the people. So if you take this room in half of you will lose 15% of your body weight. Again, a huge number, and 33%. So this part of the room will lose 1/3 of their body weight. Will lose 20% of their body weight. So these numbers are actually massive, and there is actually significant evidence today to support that if you go on to semaglutide, there is a more than even chance, about 90 to 95% chance that you will lose weight. It is not such a situation now that there is a chance that you will lose weight. You will lose weight, and there are very few non-responders to these group of drugs. So if you see the 20% weight loss, which I think is where we start comparing it with bariatric surgery, you find that 1 in 3 people, as I said to you, lose the weight of 2.4 milligrams. And this is seen across the board: step 1, step 3, step 4. I'd like you to focus on step 8, which is a comparison with liraglutide. And as you can see, about 40.6% of percentage of participants lost that weight, 20%. And comparing it with liraglutide, which again is a GLP-1 receptor agonist, in that group only 6.5 lost 20 kilos of weight. So it is so much more superior to to liraglutide, older generation. And again, the other thing I would like you to focus on in the group with type 2 diabetes, which is step 2, and that is also pretty illuminating, because we know that diabetics find it more difficult to lose weight, and as you can see, that is exemplified out here. You find that not so many people with diabetes will be able to lose 20% of weight. So this is something which exposes the real world situation. A natural progression from this is the question which is asked: so will I lose lean mass as well? Comparatively, if you're losing water from a crucible, then everything, you will lose all components. But if you look at the amount of lean mass loss, it is actually increased by 3.5%. This is comparatively, and the total fat mass comes down by about 4%. And this is reflected. This is the sema-lean study, and you can see the hand grip strength, which is a function of how your muscles perform. You find that the muscles start to perform better, and muscle strength becomes more impressive with semaglutide. Now, this is about weight loss. This is about muscle strength. This is about losing your excessive body fat. Now we move on to something which is more important. I think waist circumference. I think recently we was looking at some data, and Shomit was telling me about this only yesterday, that almost definitely today BMI will not be an important issue anymore. And I'm not going to steal his thunder, because I'm sure he's going to be presenting on how waist circumference is about to become the only modality by which we grade obesity. Uh, it makes you lose waist circumference to the tune of about 15 centimeters. Your inflammatory markers come down, your diastolic and systolic blood pressure comes down, as well as your noxious triglycerides. And if you look at people with diabetes or people with pre-diabetes, a large portion of them get a 2% HbA1c reduction, which was only previously attained by insulin, but insulin had the problem of weight gain and hypoglycemia, which you don't see with these group of drugs. And indeed, if you put obese people on semaglutide, about 80% with pre-diabetes will reverse to normoglycemia. So, as you can see from this cartoon on the right hand side, that from everybody in that room which was having pre-diabetes after usage of semaglutide, they all only two people remain pre-diabetic and the others have become normal. Now to come to the semaglutide and side effects, the same side effects that we've seen with all GLP-1 RA, no increased risk of any kind of bad events. There has been some news, or I think there's been some kind of a gossip about retinopathy and NION. I don't think that has been proven in clinical trials, and I'll tell you a little bit more. There is a trial with semaglutide on retinopathy called Focus, and that is almost nearing completion. And if there was any kind of a bad noise of retinopathy or NION, I think the committees would have actually stopped the trial and not let it persist for this kind of a situation till now. So I don't think there's any kind of problems with side effects other than the ones that we usually see with GLP-1 RA, and this has been studied in more than 60,000 patients with 38 million patient years since 2018. So it is indicated for if you have a BMI of more than 27 with one comorbidity, or more than 30 with no other comorbidity. I think if you look at the Indian data and the obesity white paper that we published last year, the Indian classification for obesity, I think Dr. Hari Kumar was also part of that, and it has been brought down to 23. So I think we can safely consider that Indians, maybe not obesity. Yes. Yeah. 23. 23.
Overweight, overweight, overweight.
It's been
Yeah, yeah.
changed. It's been changed. It's been changed to obesity. Okay. So there's a white paper last year, published last year. Mm. So, I'm not saying that has been accepted, but that is a theory. I'm saying nobody is normal. So, it also leads to a reduction of cardiovascular events, as we saw in the SELECT study, and it is used in the step up algorithm. You start off with 0.25 milligram for 4 weeks, then you go to zero point 0.5, then you go up to 1, then 1.7, and stay at 2.4 milligrams. So you need to take it for 5 months to reach the maximum dose. And this dose escalation can be delayed, and this can be made softer if the patient finds it difficult to tolerate. There's no harm if you take 2 months in a particular dose and delay the progression to 2.4 milligrams. And if you're getting an expected weight loss, which is very significant at a lower dose, you can stay at that dose and not up titrate any further. Now, there is, of course, good news coming, because there's lots of semaglutide coming into the market being made by Indian partners. But I think there is one thing that we have to be a little cautious about the quality, about the purity, the consistency in the cold chain. And I think it is imperative for all of us physicians to check on these factors before we start running into this huge rigmarole of prescribing less expensive brands, because they have not been approved for a long time. They are synthetic, and with, as I showed you, something like 7.8 million patient years experience with semaglutide, they probably do not have that many numbers. I think it's probably less than 100. And there is no cardiovascular data, renal outcomes, peripheral arterial disease data. And this is, of course, just an Indian approval. And we have to be careful about the consistency and the cold chain that is associated with this. But then again, I will say this is something that we should welcome, but we must make sure that we are scientifically correct about usage of these products. So I will conclude by saying that semaglutide provides substantial and clinically meaningful weight reduction. 1 in 3 people will lose 20% of body weight. It's almost like bariatric surgery. And again, I think this is very important to know that it has been studied across the STEP programs, and the sustain and pioneer, of course, are the two problem things with semaglutide for diabetes. But it's important to know that when we use products, we must have enough evidence of its benefit. And I think semaglutide ticks all the boxes. Thank you very much for listening.